I had a patient who was quite reluctant to consider antibiotic treatment for Lyme disease after being unable to tolerate his initial treatment. He was able to tolerate treatment by starting with a lower dose of antibiotics. I have patients with issues with gastroparesis, leaky gut, diarrhea, candida, yeast, constipation, and irritable bowel that have made it difficult to tolerate antibiotics. I have patients who have had a Herxheimer reaction after an antibiotic for another condition. A Herxheimer reaction, also known as a Jerick-Herxheimer reaction, is a transient clinical phenomenon that occurs in patients infected by spirochetes who undergo antibiotic treatment. I have patients who cannot swallow pills and others who cannot tolerate liquids. I refer my patients to specialists as needed to determine if there's another underlying cause for their difficulties with medications. I refer to gastroenterologists to rule out other causes for stomach problems. I refer to other specialists to rule out an autonomic disorder as a cause for their stomach issues. I also have patients who are still sick after changes in their diet and alternative medicine. I review the risk of antibiotics against the risk of remaining sick with Lyme disease. Some of these patients are still unwilling to consider antibiotics. I advise my patients to avoid alcohol and processed sugars. Here are a few treatment options I have incorporated in my practice for those willing to be treated. I introduce treatment slowly. I start out with single therapy rather than combination therapy. I have started patients with 50 milligrams of doxycycline instead of 100 milligrams. I have started with 25 milligrams of doxycycline at times with a liquid formulation. I have lowered the dosage of cefuroxime from 500 milligrams twice a day to 250 milligrams twice a day. I have prescribed Zithromax 250 milligrams every other day or every third day, as Zithromax has a long half-life. I have lowered the liquid atovaquone at 750 milligrams twice a day to atovaquone at 250 milligrams twice a day, or a pediatric dose of atovaquone at 62.5 milligrams twice a day. The lower dose of atovaquone are available in an oral form combined with proguanil. I have started with once a day for some patients. I typically raise the dose if tolerated. I find the lower doses helpful in some patients without having to increase the dose. I have not found intravenous ceftriaxone as helpful as I would like. Intravenous ceftriaxone enters the stomach through the circulatory system, leaving me with the same gastrointestinal issues. Moreover, intravenous ceftriaxone is not the treatment of choice for tick-borne co-infections. I follow my patients starting at 1 month to determine if they are tolerating the lower dose and to determine their response to treatment. I advise my patients to contact me if they're having problems with tolerating the lower dose to work out a solution.